Hello, my name is Christian Maat. I'm gynecologist from the Medical University in Innsbruck in Austria. And I'm thrilled to join you today to share the third installment of the Precision Endometrial Cancer, Personalized Treatment Strategies for pMMR and dMMR Endometrial Cancer, an industry-supported symposium that was presented at the IGCS 2025 Annual Global Meeting in Cape Town, South Africa. The first segment will be presented by Dr. Ramesh Eskander. He's a professor of gynecologic oncology at the University of California, San Diego, Moore's NCI-designated Comprehensive Cancer Center. Dr. Eskander also serves as the Medical Director of Clinical Trials Office and is the Gynecologic Oncology Fellowship Director at UC San Diego School of Medicine. Dr. Eskander is an experienced clinical trialist with long-standing experience in both the development of early and late-stage clinical trials, as well as the conduct and completion of gynecologic cancer studies, and he was the PI of the game-changing Energy DY18 endometrial cancer trial. And this sets the stage for today's topic, approaches for dMMR endometrial cancer. Introduction of immunotherapy was really a revolution in this subset of approximately 20 to 30% of endometrial cancer patients. We look forward to listening to Dr. Eskander in order to better understand this important issue.
Thank you, Christian. It's a pleasure to be here with you guys this afternoon. I did want to just take an informal poll by show of hands, if that's okay, because I'm fortunate enough to talk about a topic where I feel like there's less controversy in the dMMR space, but how many of you in your regions of the world in which you treat patients have access to immune checkpoint inhibitors for the treatment of dMMR recurrent or advanced stage patients? So interesting. I'd say it looks like a little bit less than half of the room, actually, just by eyeballing it, maybe half the room. Okay. So as we recognize, endometrial cancer is a disease with a rising global burden, to some degree for reasons that we have yet to define. It actually has now exceeded in our US cancer statistics that's published annually, the number of deaths from this disease has exceeded the number of deaths from ovarian cancer. And in clinical practice, many of us are seeing a shift in the demographics of the patients that we're treating with systemic chemotherapy, where historically the majority of those were recurrent ovarian cancer patients, and now we're seeing either an even distribution or in some cases a higher proportion of metastatic recurrent endometrial cancer patients who are receiving systemic therapy. Alex very thoughtfully took you guys through the TCGA data that really transformed the management of this malignancy. But I wanted to also take a moment because we are sometimes see this ambiguity around how we're using the terms prognostic and predictive for response. And when we look at the data, what we recognize, if you look at the bottom box, and this is, I challenge ourselves as we look at this, this was suggesting that these molecular classifiers are prognostic for a clinical outcome. But if we ran this same assessment today for patients that were treated a year ago, we may see a very different Kaplan-Meier curve because we've identified an effective treatment strategy for which these patients respond. So suddenly, dMMR wouldn't appear to be prognostic for a poor clinical outcome because we have a very effective therapy to help prolong these patients' lives and improve survival. So as we are seeing the science evolve, we're going to recognize that some of these biomarkers that have been identified as prognostic for a poor clinical outcome may no longer be the case because we've been able to identify effective therapeutic treatment strategies to improve clinical outcome. We know that mismatch repair deficiency is the most common molecular aberration in the context of immune predictors of response when we look across solid tumors in endometrial cancer, meaning it's most frequently identified. And it's approximately, across all the studies that we're going to share, 25% of patients with advanced stage or recurrent disease are going to have aberrant expression of one of the mismatch repair proteins. And what this results is a progressive over time phenotype, because when you have absent expression of these mismatch repair, any one of them, you get an accumulation of non-synonymous mutations, higher tumor mutational burden, predictive of response to immune checkpoint inhibition. And we saw this, as was reviewed already, in a slew of studies that looked at single-agent checkpoint across many solid tumors. In fact, the largest phase 1 clinical trial ever conducted was in this setting, looking at checkpoint inhibitors in patients across many disease settings. And we saw a very consistent signal. Although initially we said, look, the objective or overall response rates were in the 45 to 50% range, but was really meaningful is that when patients responded, the median duration of response was not reached. So we had patients with recurrent disease who had 3 or 4 prior lines of therapy who were then challenged with these drugs, who went into remission, and if they responded, didn't develop a disease recurrence. And that was really what changed the paradigm of how we interpret the efficacy of these drugs, and really it's transformed multiple solid tumors. But we also recognize that the disease is beyond just dMMR, and we've had a hypothesis about how combining cytotoxic chemotherapy with immune checkpoint inhibition can augment response. And this was proven first in clinical practice in lung cancer, but has seen an evolution across several solid tumors. For the sake of time, I coalesced the schemas of the several phase 3 trials in endometrial cancer into this generic schema that was essentially highlighting that these are advanced stage recurrent metastatic patients. They could have received prior adjuvant therapy with a chemotherapy-free interval of 6 to 12 months. Some of these studies allowed carcinosarcoma, but a small proportion. It was capped at 10%. And then the duration of maintenance therapy varied. And as we know, the DuoE was a 3-arm study that incorporated also the PARP inhibitor olaparib in conjunction with durvalumab in one of the arms. These are the publications for reference. And then lastly, we've spoken about this several times so far at this IGCS meeting, which is the profound benefit with using immune checkpoint plus chemotherapy and immune checkpoint maintenance in the mismatch repair deficient population, a very remarkable and consistent signal. But also, there was preliminary data that emerged from either institutional retrospective studies or from ancillary data for prior studies that was hypothesizing that the magnitude of benefit with epigenetic alterations was not as great as if there was a somatic mutation in the mismatch repair genes. But as everyone is aware, the vast majority of mismatch repair deficiency is driven by epigenetic loss of expression, MLH1 and PMS2, rather than mutation. So in the NRG GY018, we looked at this, and if you look at the very far right panel here, although small numbers of somatic mutations, we appeared to show that, look, the benefit is preserved irrespective of the mechanism of loss, which is important. And also on the left-hand side, I want to call your attention to the fact that although chemotherapy is effective in this population, when we combined immune checkpoint with chemotherapy and continued immune checkpoint as maintenance, we saw a doubling of the complete responses and a meaningful improvement in the overall response in the entire population, 82%. And this has resulted in US FDA approvals, international global approvals of immune checkpoint inhibitors with systemic chemotherapy as maintenance because of the response. I have already mentioned that there is a component of these patients that despite having a biomarker that is predictive of response, we have still failed to see a long, durable benefit. We're seeing patients still recur early on in therapy. And I did want to highlight 2 abstracts from ESMO once again. The first by Dr. Weston, because there was a hypothesis that maybe these are patients that are mismatch repair deficient, but there's some degree of heterogeneity and the tumor mutational burden is not high. But when we looked at the data from DuoE, which was presented at ESMO, we see that whether it was a TMB high or a dMMR signal, the morphology of these curves is identical. You're still seeing these progressors almost the exact same frequency. And in a small exploratory translational project from the ATTEND study, there was a hypothesis that maybe high aneuploidy is informing this lack of response. We don't know. This is a very early subset of patients. You can see 10 total, 6 in one cohort, 4 in the other. But there's also literature about the implications of a high aneuploidy score in immune checkpoint response amongst other solid tumors. And one of the things that we don't quite understand yet is, could this high aneuploidy impact antigen presentation? So even if you're TMB high, if you can't express the antigen, irrespective of immune cell infiltration, you're not going to get activation and then an immunogenic tumor response. I think more work has to be done in this space because we still have 30% of these patients for which we can do better. Now, the Keynote B21 study looked at a higher risk adjuvant population, and here I want to focus on the mismatch repair deficient cohort. Once again, in this trial, you could see that approximately 1/4 of patients are mismatch repair deficient, a very consistent signal. I wanted to highlight in the right-hand aspect of the slide the very heterogeneous nature of the patients that were enrolled on this trial. You could see you had stage 1A, 1B, all the way to stage 4A, 4B. Very, very broad endometrial cancer population. They used some of the molecular classifiers for risk stratification to broaden the eligibility criteria. A large proportion received radiation therapy, and you can see about half and half endometrioid and non-endometrioid histology. In the intent to treat population, there was no significant difference in clinical outcomes. You could see that these essentially completely overlap for disease-free survival. But when we looked at the subset, again, this is an unplanned, or I should say a non-alpha allocated ancillary assessment of this cohort, you could see that in the mismatch repair deficient population, this was a planned assessment, there is a benefit. And this really calls into question what we do in these patients because, again, this is a very consistent signal. The hazard ratio is 0.3 across all these studies in mismatch repair deficient populations receiving immune checkpoint. Now, importantly, we have to ask ourselves the question, do we need chemotherapy at all in these patients? And there are two active trials, the Keynote C93 and the Dominica study, which are comparing carboplatin paclitaxel to single-agent immune checkpoint inhibition. Now, justifiably, we're going to be in a quandary when these trials read out because we're going to force ourselves to cross-trial compare between single-agent checkpoint and the intervention arms of RUBY and NRG-GY018 and DuoE looking at chemotherapy plus checkpoint and trying to figure out, can we get rid of chemo or not? Because the control arm in these studies was developed before we knew the positive results from these various phase 3 trials. And I also wanted to talk about the LEAP-001 study, which looked at replacing potentially carboplatin and paclitaxel with lenvatinib and pembrolizumab. We know the Keynote 775 efficacy in the recurrent setting, which we'll review. And again, this randomized patients to lenvatinib, pembrolizumab versus carboplatin and paclitaxel. With respect to the primary endpoints for PFS, you could see on the right-hand side that there was no improvement in clinical outcomes in these cohorts. But what was interesting, if you took the patients who had prior adjuvant chemo, which was allowed as long as the chemo-free interval was 6 months or greater, there appeared to be a suggestion that lenvatinib and pembrolizumab was efficacious beyond carboplatin and paclitaxel. This is hypothesis generating. We can't draw definitive conclusions from this data. I will tell you what I find most interesting about this is it argues against adopting a blinded platinum-free interval paradigm from ovarian cancer and putting it in endometrial cancer. And that's for another symposium that we can hold at a later date. Now, management of recurrent disease. Historically, the paradigm for endometrial cancer was a very linear, few choices. But now we've seen that this has changed dramatically. Our options in the earlier line therapy are much broader. We're using biomarkers to inform treatment strategies. And that's impacting what we do at recurrence. Why? Because the Keynote 775 combination of lenvatinib and pembro, when it was tested against physician's choice chemotherapy, was conducted in a study where no prior immune checkpoint was incorporated as standard of care. So we now have patients that are exposed to checkpoint with cytotoxic chemo who are progressing, and we're having to make a clinical decision in practice. If you don't have a clinical trial for which the patient's eligible, what am I going to use for treatment? Now, there's been several publications about progression on IO, and we know that we treat patients in clinical practice, some of whom complete their maintenance therapy and then recur. Some progress while they're on combination of chemo checkpoint. Some progress while they're on checkpoint maintenance. And this may potentially inform how we manage such patients. Are they early hyperprogressors? Are they primary resistance and progressing? Is it an acquired resistance of some sort? And this was a very thoughtful paper that was published back in 2023 that looked at, well, what can we do to quote-unquote reverse resistance? I will tell you, not long ago, I remember my days as a fellow, and there was a lot of research on reversing platinum resistance. And then we realized we're going to abandon this theory and we're going to develop new novel drugs that do us better. Thank God. So I will say that this idea of reversing immunotherapy resistance, we have to approach with a similar degree of caution. But we also recognize immunotherapy is not cytotoxic chemotherapy. And there are ways that we can augment immune response. And you could see here a litany: vaccine-based strategies, alternate checkpoint inhibitors, and these combinations. We can also learn from other disease settings. This was a checkpoint after checkpoint in renal cell carcinoma, and it looked at patients who had received prior checkpoint inhibition, and it randomized them to atezolizumab plus cabozantinib versus cabozantinib alone. And it didn't appear to show that when you re-challenge these patients, we saw a clinical benefit. I'm going to pause here for a second because we also recognize that all of these diseases are not the same. So we can't just blindly say what we see in renal cell, we're going to see in endometrial. And I will, the disclaimer is that we are working on this data in the NRG GY018 study. This is a cooperative group trial, so the data actually is governed by the NCI and it's released to us. We're collecting all of the data for these patients post-progression, many of whom, because again, this was a cooperative trial in the United States where we had access to lenvatinib and pembro, and a trial that mandated unblinding at progression. So we're going to have this great data, and we're cleaning it right now, and we hope to share it with you at a future meeting to show the utilization and the potential response rate to re-challenge with TKI, lenvatinib plus pembrolizumab after prior chemo, IO, and IO maintenance. We also have data from Stephanie LaRue, again, a very thoughtful study. This was advanced recurrent endometrial cancer. You had cabozantinib plus nivo, again, the lenvatinib pembro idea, TKI, checkpoint, versus nivolumab alone. But they were thoughtful by developing an arm C. An arm C allowed crossover at progression with prior IO from arm B, and it gave patients cabo-nivo. So you had an opportunity for prior IO followed by TKI IO, and they did see responses in a cohort of patients. So we may have a population of these mismatch repair deficient patients or proficient patients who are exposed, who can be re-challenged, and we still elicit a response, but really more work has to be done. This was a paper published by Peter Rose. It's a small case series out of the United States. Importantly, these were all mismatch repair deficient patients. They had all received checkpoint at recurrence, meaning they're not primary adjuvant treatment or primary metastatic disease, but these patients were re-challenged. And what was beautiful about this is that they saw a reduction in tumor volume in every one of these patients. So what does this mean? It's a small subset of patients. They're all mismatch repair deficient. Essentially, all of them had progressed. We don't know, but it just makes me think that we collectively are going to need to work hard to get more real-world data, theoretically, but also from our clinical trials to better define the opportunity. And then I just wanted to end on the fact that there are active studies. This is an NRG cooperative group study looking at, again, the opportunity for re-challenge with checkpoint after checkpoint. Now, whether this is resensitization, whether it's tumor heterogeneity, whether it's a disease, here they mandated a 12-month IO-free interval. Well, is that really IO resistance? Maybe not. Maybe you had a response. The response was durable for a period of time. You stopped therapy. More than a year later, the patient progresses and re-challenge. I will tell you in clinical practice, I have re-challenged with checkpoint in patients who've completed treatment and then had a recurrence with repeat responses and durable remissions. And whether that's with lenvatinib plus pembrolizumab or an alternate IO strategy, I'm seeing these in clinical practice, as I imagine many of you are as well. So there are responses in a cohort of patients, and it's going to be incumbent on us to really spend time to understand more about who those patients might be. Thank you so much for your time.